Hello, welcome everybody. My name is Mike Ujiki. I'm a minimally invasive surgeon in Chicago, Illinois. I focus on foregut and bariatrics, and today I'm very excited to discuss how we assess hiatal closure during paraesophageal hernia repair. We have two esteemed speakers tonight. We have Dr. Christy Dunst from Portland, Oregon, and Dr. Kevin L. Hayek from Cleveland. And the objectives for tonight will be to talk about key considerations for how we determine the appropriate reconstruction of the hiatus during paraesophageal hernia repair, what the challenges are to doing that technically, and what technology we may have that can help us during the repair. And then we'll also talk about how we handle and work up patients who have dysphagia after paraesophageal hernia repair. Dr. L. Hayek will pull up his slides here. So just this is a CME event. The target audience is really surgeons that take care of patients with foregut disorders, in particular hiatal hernias. The objectives I've already described. I think that there are no conflicts that I think will prevent any CME for this. You can see the conflicts of interest there. And this is the information on how to get your credits. If you have any questions, you can certainly email us and let us know, but this would be the information. So I'm very happy to introduce Dr. Kevin L. Hayek, who's an associate professor. I'm sure most of us know both of our speakers tonight. He is at the Metro Health System, Case Western Reserve University School of Medicine, and head of endoscopic surgery, as well as hepatopancreaticobiliary surgery at Metro Health. He completed his undergrad at Harvard. He then came to Case Western University for medical school in 2006, and he went on to complete general surgery residency and an MIS fellowship at Cleveland Clinic, where he worked for about 6 years until 2019, when he was promoted and moved to the Metro Health System. And his clinical and research interests include minimally invasive foregut surgery, endoscopic surgery, as well as HPB. Kevin, we're really happy that you took time out of your family life to be with us tonight. And we look forward to hearing what you have to say on the role of the functional luminal imaging probe technology for assessing hiatal closure. Thanks, Kevin.
Thank you so much. And I just want to thank everyone for being on tonight. I'm just going to kick us off with a couple thoughts about how we assess the hiatus during closure and the role that I think many of us are starting to at least investigate and look at for some objective measures. So just starting with the way that we used to do this, and many of us used a bougie. This is something I had to dig up from YouTube. I haven't used a bougie in quite a while, but I think using a bougie was very typical for my practice in the beginning. So right as we close the hiatus, passing either a 56 or a 60 French bougie to make sure that we're not closing that too tight. And I think that was an appropriate method for the time. Another way to do that was to keep it in during the fundoplication. So whether or not that was a Nissen fundoplication, or now many of us have moved to toupee or partial fundoplication, a bougie was one of the things that many of us do or have done in the past. Another is endoscopy, which I think is a great way to look prior to and immediately after closure of the hiatus, as well as in this case, a fundoplication. We can see that omega loop that's typical for a Nissen fundoplication. And it would also be used in many instances as a sizer, however, much smaller, obviously, than a 56 or 60 French bougie. And then the time valued visual cues, using the tip of the instruments to measure and sort of calibrate the closure. Knowing what the size of those instruments are, you could kind of see, and we would often dictate in our operative reports that 2 instruments could enter the hiatus without any difficulty, and felt good about that. However, as many of us know, that didn't necessarily lead to optimal outcomes, and some of these patients ended up with dysphagia. And for this reason, we're looking today at functional lumen imaging probe technology, or FLIP technology. And this is a balloon catheter with impedance planimetry sensors with a pressure transducer. And this can be inflated at a sphincter. So whether or not that's the GE junction, the pylorus, we can find visual cues and numbers. So diameter here on the left-hand column and distensibility index. And what that equates to in real time is the ability to measure the tightness or the compliance of a sphincter. The higher the DI, the more compliant or the looser that structure is. And obviously the diameter is just a direct measurement. And from the work of our other two panelists who've really poured into this over their career over the last 5 to 7 years, is really understanding what an appropriate DI is for an anti-reflux mechanism. And what Dr. Ujicki's group and Dr. Dunst have found is that really under 2 is associated with postoperative dysphagia, whereas 2 to 3.5 is sort of that sweet spot where anti-reflux is appropriate. And then over 3.5, we've learned is actually considered not appropriate for anti-reflux mechanism and may actually lead to either recurrent reflux and also in some cases recurrent hiatal hernia. So what we found in as well in our group is that we noticed that the largest drop in the distensibility index was actually after crural closure, and this really speaks to the value of an appropriate crural closure, and that's the topic of tonight's webinar. The drop after fundoplication was actually less impressive, so to speak, and so what you could see, though, is that zone of pressure increase when you added a fundoplication. Again, this is from Dr. Ujicki's group. And this is the protocol that we used at our center as well, which is to measure at 30 and 40 mLs with the balloon pressure being over 15 millimeters of mercury, the patient position in reverse Trendelenburg, releasing the pneumoperitoneum and allowing for about 30 seconds for each measurement for stabilization. And that leads to the key question, which is it possible for us to tailor our hiatal hernia repair for each patient using FLIP values as a benchmark? So we took a look at our own patient population and started using this in real time for various hiatal hernias, the majority of which were type 1. However, there were significant type 2, 3, and 4, with 94% of these patients having symptomatic hernia, as well as 58% with reflux. So ultimately, after getting comfortable with this technology, I was able to change management 39% of the time. So these patients, in a third of those patients, fundoplication was deferred altogether. And I was finding this was actually later in my series when I felt that the DI was appropriate after the hiatal closure. The type of fundoplication was altered in 46%. It was loosened in 15% and tightened in another 8%. So here are just some key examples of patients post-hiatal closure. So here is after hiatal dissection, a DI being in the 5.1 range, dropping to about 3.5 after closure, and a Toupet fundoplication leading to a DI of 0.7. And this is too low, as we talked about before. So this has actually led to a revision where it took a few stitches out and got that DI to a more appropriate level. Here's another case of post-hiatal dissection being at about 7, not really a significant enough drop after closure. The fundoplication, as mentioned before, didn't do too much, but we tightened that with an additional tightening stitch, and that was during a Toupet fundoplication. In another patient, post-hiatal dissection was 5, post-closure was 5, and for this reason, this patient was a younger patient. This was one of the few Nissen fundoplications performed in the past few years for me. So again, showing in our study population, this first line is after hiatal dissection, kind of running in the 4.3 range. After cruroplasty, dropping down to 2.7. After hiatal dissection in the 50 ml group, down to 2.5. This is an open access article, and I know that this brings up a lot of controversy, and I'm happy to take any criticism tonight, talk through some of this, talk about our protocol. but also provide the paper for anyone who wants to dive deeper as well. We did have about 17% asymptomatic recurrence. Those were in type 3 patients, both of whom ironically had to pay fundoplication. So far, based on a 6-month follow-up, this is ongoing. We've not seen the need to proceed with fundoplication in any of the patients who had their fundoplication deferred. So our future questions are whether or not we can use FLIP technology to effectively assess the closure and to give an optimal anti-reflux outcome without fundoplication. And then ultimately, when we do perform a fundoplication, which one should we perform and how should we fashion that using more objective measures? And finally, can we use these FLIP values to correlate to recurrence risk? And we know that prospective studies are needed, and I think we're going to hear a little bit about that from Dr. Dunst and Ujiki. Thank you very much.
Kevin, that was excellent. Thank you. And I think that's a good kind of introduction to, EndoFlip technology. I want to introduce Dr. Christy Dunst. Means a lot to me. She actually, even though she looks about 15 years younger than me, she actually taught me how to do foregut surgery. She's an esophageal surgeon at the Oregon Clinic in Portland, and she joined there right after finishing a thoracic foregut fellowship in 2006 at University of Southern California with Dr. Demeesters. She's a medical director of foregut surgery and the program director for their complex GI foregut surgery fellowship. And her practice, as we all know, her research and practice focuses on GERD, Barrett's, hiatal hernia repairs, motility disorders, and cancer of the esophagus. Neither of our two speakers really need an introduction. I'm sure everybody knows them, but we're very happy to have you, Christy. Again, thank you for taking time out of your personal schedule to spend it with us tonight. I want to get your thoughts on the talk by Kevin, and before that, I'd like to hear a little bit about what you think. Just a real quick, key, points and your experience with hiatal hernia repairs. Like, what are some technical aspects, or even non-technical, in terms of the pre-op workup for these patients? What you think that a foregut surgeon who's just starting out really should focus on in order to give patients kind of an ideal outcome when it comes to hiatal hernia repairs?
Well, thank you so much for inviting me. And I just scanned through the list of attendees. And hi, everybody. It's so great to see some recognizable names. I'm really glad you guys could join us. Your question, I mean, I could talk about this for days. So your question is broad. Like, what are the key points of paraesophageal hernia repair? And I think I would like to just sort of give a little bit broader perspective. You mentioned my training. So yeah, that's when I trained. It was a long time ago. And when I learned how to do paraesophageal hernias, my favorite operation during fellowship was an open transthoracic paraesophageal hernia repair. So that's the way we did it 90% of the time. And we had a very specific way to measure the crural closure, and that is it should be a tight sphincter on your fingertip. Very specific. Depends on how big your fingers are, right? But we never used a bougie. Never used a bougie on the crural closure. I was trained that the bougie was for the fundo, not for the crural closure. But we did have sort of a routine. You kind of knew it. You knew when it was too tight just by the feel of it. And when we moved to laparoscopy, we all lost that. We lost that sensation. And so then people started tailoring around the bougie. And then people started, like Kevin said, putting different instruments. And if it's open a little, or putting two in, or all these different ways. And it was really challenging. And so I think that is really what we're gaining back with the flip. It's a little bit more sensitive, reproducible, but we don't have the answers. And so I love looking at all the data. I love talking about it. And we're starting to figure it out. The the key portions of the procedure, when you look at that, I think that, again, I want to give you a little bit more of a historic perspective. When the famous landmark Oschlager paper came out and had early adopters of laparoscopic paraesophageal hernia repair, they were all experts, awesome esophageal surgeons. And then you find that the, late recurrence is 50%. And that was really disappointing. And I think all of us, everybody in that study, my partner, Lee Swanstrom, your mentor, Yujiki, was part of that study. And all of the authors went back to their places and started really looking at the details. And what we started to do was, what was better in the open era? Like, what was better? Because their recurrence rates were way low, 2%. So what was it? It's more than just adhesions, so the concept of making.
So freeze.
Yeah, Christy froze for a second. Kevin, while we're waiting for Christy to join, you were going to be next. I was going to ask you, I understand that asking kind of keys to, oh, Christy's back.
Am I back? It says,
Yeah,
it
you
says
froze.
unstable. So
Yeah,
sorry
you
about
froze
that.
for a second, but why don't you keep going? You kind of got frozen when you were talking about why the recurrence rate was so low back in the day, and then we kind of lost you.
Well, so people started looking at what were the techniques that we did during the open surgery. We made sure that we had a full sac reduction and excision, high mediastinal dissection up to the arch, dividing the vagus nerves along the bronchi, all those kinds of mobilizations. And that kind of quickly became standard of care. Everyone kind of quickly got onto that, at least in the United States. And the outcomes didn't change all that much, the studies. And so people started paying attention to the crura. What are we doing? Should we put mesh in there? Should we not put mesh in there? Do we measure tension? Do we not measure tension? And frankly, I think that we are still working on that. And the flip is part of it, because we want it tight, but we don't want it under tension. We don't want it too tight that they can't swallow, but we don't want to leave it loose where there's a gap and then the recurrence rate. So this is evolving, and I think it's a key portion of the advancement of this field is to study it. I will say, regarding your talk, your data is great, and your data is really along the lines of Mike's in terms of the numbers. Ours is kind of not, to be honest. We're accepting a much lower DI these days, because when we started to tailor it to the DI of like 2-ish, we had to leave a gap we didn't like. So we've dropped that down to 1. And if it's less than 1, yeah, you get a grasper in there, stretch it out until it's 2. But we've noticed, and this is not collected data quite yet, that the dysphagia rates are fine. Like, they're okay at 1. Less than that, no. But it is evolving for sure. On the crura alone, we talk about fundo as a separate issue, but I appreciated that data for sure.
Christy, do you guys, and Kevin, I'll ask you the same question. One thing that we found is it's not just about dysphagia, but also gas bloat. We find that the gas bloat rates also work very closely to dysphagia. And so that ideal range we found also lowered the number of patients that we had with significant gas bloat. Is that something that you guys measure as well? Because one to me is achalasia. I mean, when we do an endo flip, when we do an endo flip at the time of a myotomy, obviously, yesterday, Monday, we did a poem on somebody that they started at 0.2. But that's actually uncommon. But I would say 0.5 to 1 is very common. So I
agree.
How closely are you following the patients in terms of their symptoms, like gas bloat, for example?
Right. Well, I agree with you 100%. Less than 1 is achalasia. We don't let someone leave the OR with a less than 1. But I was for a while following your data and making it 2. Like, loosening it up to 2. But then my partners, we all tried it and we all discussed it, and they were like, well, I'm not loosening it. If I like the closure, I'm not going to loosen it if it's 1.5. So then we've been drifting a little bit. As far as bloating, I think the bloating really has more to do with fundo. So, and of course, if you're doing a curl closure and a fundoplication and you have the DIs, and then you're going to follow them clinically, it's hard to tease that out. So I think it's still evolving. Your data is very compelling.
Yeah, I would say that, it's not like if you're under 2 that the patient necessarily has a bad outcome, but you're just increasing the chances of a less than ideal outcome. And I would just say that when we look at normals, and we haven't done that, but that's something that the Northwestern gastroenterologists have done. They have found that only 5% of the normal population, meaning a normal esophageal population, has a DI less than 2.
Yep.
And so there are some people out there that live with a distensibility index less than 2 and are fine. They don't have, frequent dysphagia or any other symptoms. So I wouldn't say that like under 2, is for sure you're guaranteed a problem, but you're definitely more likely to. And I think the other thing we should clarify with people is when you're measuring the distensibility index during surgery, are you doing it with pneumoperitoneum or not? Kevin mentioned, and that's the protocol that we've discussed or that we've published, is to desufflate the abdomen and make sure that we're speaking the same language. Because I do know that there are people out there that are, getting distensibility index ranges that are lower than 2 and having good outcomes, but they're also measuring it with pneumoperitoneum. And we know that pneumoperitoneum decreases the distensibility. So, Christy, you guys are doing it though without pneumoperitoneum, or is it with?
Yeah, no, we follow the protocol that we wrote up for the white paper.
Okay.
So we do it without, but there are other places that have lower numbers than yours as well. And so we've tried, you and I particularly have tried to standardize this protocol, right? And I just don't think we have all of it worked out. That's all.
I would also point out that now we've got over 1,500 patients that we have data on, and actually our range has even changed a little bit, but it's gotten higher. So it's actually 2.5 to 3.5 now is more the ideal range. And yeah, I'm not sure why there would be that discrepancy. It would be, interesting to maybe look at some of the differences, but how you measure it makes a difference. And I think that that's definitely something that we need to standardize. And Christy, you know this, but there will be a paper coming out with kind of protocols in the foregut journal, which in the future we hope. I think it will be, and this year at some point, and I think that will help us all standardize our approach to using EndoFlip during hiatal hernia repair, and that way we can all kind of speak the same language. We all use the same volume fills, we use the same length of balloon, we use pneumoperitoneum or not, we use Trendelenburg or not, because those are all factors that can make a difference. And it is a highly sensitive balloon. And so, if we're not all doing it in the same way, we can see some differences. Kevin, what do you think about that? Your protocol is similar to ours, and are you willing to leave the operating room with the distensibility less than 2, for example? And if you have you noticed any problems with that?
Yeah, so I, like many of Christy's colleagues, felt similarly when I was originally measuring the numbers. And this series that I published, I know it's small numbers. It was our only primary, and those that we were doing EndoFlip-ons was a little bit later in the years of practice. But before that, I did size over a bougie, and then I can tell you that I had a real risk of needing to dilate a few patients here and there. I do a lot of endoscopy as well. And I definitely dilated even toupees in the past. And I have dilated one patient in 5 years, and that patient had a DI under 2 in the OR. And I remembered going, this can't be under 2, and I'm gonna just, that looks good, I'm gonna leave it. And it was the one patient I've dilated in about 4 or 5 years now, and the DI was under 2. And I do just get a little bit nervous seeing ones. And as you said, I mean, I've done poems on patients with achalasia where it's 1 to 1.5. You know, it's not necessarily under 1. And so I do, like you said, I feel like in the few patients that it's been under 1 or under 2 that I've been worried about postoperative dysphagia. And likewise, even when we tease out, the lower that DI is, the more likely they are to say that they have difficulty swallowing, even in the absence of fundoplication. So I've been having patients now a number of patients now that have deferred fundoplication, where the DI is at 2 to 2.5. And those patients, some of them have had dysphagia. But I can tell you, I feel a lot better about a patient who has dysphagia in the absence of a fundoplication than I do in someone who has a fundoplication, where now I'm worrying, did I sew it too tight? Now I know it's the hiatus, and I can usually ride that out.
Yeah, and they also, those are, you know, you dilate that. It's a whole lot easier to dilate that than
Yeah,
fundo.
dilate that. You
Yeah.
know, exactly, because you're not dilating a fundo. You're dilating native
Right.
anatomy. And a lot of
And
these
if you were gonna do it over bougie anyway, previously, it's sort of the same. You know, one of the things that I have been watching, I've had the opportunity lately to watch, go to the OR with some of the European surgeons. And I can tell you, subjectively at least, they leave their hiatuses way more open than I do, or any of my colleagues that I've ever seen operate. Any video I see at Sages or AFS or anywhere. And so it does give me pause, you know, that it's okay to leave it a little more open.
Yeah, Christy, I would say that the more that I've used EndoFlip in the operating room, the more that I actually trust the numbers than I do my own visualization.
Yeah.
And I have to say that our dilation rate has dropped to almost 0 when I follow the ideal range. And
Yeah.
as Evan has said, even when we knew the ideal range, there have been people where I kind of said, you know what, this is new technology. I'm not sure I trust that number, and it looks so perfect to me. I'm going to leave it there. The DI was 1.6, 1.7, and I wound up having to dilate that patient. And I won't let myself do that anymore. And sometimes it does look more open than you think. But, you know, I also, you know, think that there are differences when we release pneumoperitoneum and probably how it looks. I think there are differences, just like we do manometry in a supine, quote unquote, and standing position or upright position. I also think that, you know, we're probably, you know, seeing differences in the distensibility when people are standing up, and most people are not eating when in a laying position. So
Yeah,
I think those are
definitely.
things to consider.
Yeah, I think it's all I want to make a comment about the your personal perception, because I think that it deserves a little exclamation point for all of us, is that we did a study a few years ago. We had never wrote it up because we were trying to collect data, and then COVID happened and blah blah blah. But we took a tensometer and we recorded an objective measurement on the closure for each stitch with 4 different surgeons. And each stitch you would rate. This felt fine. This felt a little tight, but okay. And then the dang, this is tight. Okay, so that's how it was. Three things. And so we collected like thousands of these sutures and with all of the ratings. And I can tell you the correlation on the tensometer to our rating was hideous. Like it was all over the place. So I think that your point of that, you know, our ability to really assess it just by looking and even feeling is bad, which is why we've got to keep working on this flip, and we have to keep standardizing.
Before we go on, I just want to thank those who've already sent in questions, but also remind others that please feel free. We want this to be kind of an open conversation with all of you. Send in your questions and we'll read them out. I think Reg Bell, our president, asked a question about using the same technique before we actually answered that question. I think the next question is a good one, which is why not set the protocol with insufflation and Trendelenburg, and that if we make anything time consuming, it's probably less likely to be adopted. And, I'll answer that because Christy and I were kind of the first authors in the first white paper. And one of the reasons that we decided to do it without insufflation is because we have to remember that there will be times that either us as surgeons or gastroenterologists will be evaluating our hiatal hernia repairs in the GI lab without insufflation under sedation, and we wanted our numbers to be consistent and talk to each other. And so if we are talking about a distensibility range of 1 to 2 because we're using insufflation, but in the GI lab without insufflation, the ideal range is 2 to 3, then that's not going to be as helpful. And so that's the main reason. I would say that it really doesn't add much time to desufflate the abdomen while you're taking a measurement. I mean, the taking a measurement takes about 30 seconds. And so desufflating and reinsufflating does not add any time at all. I really think it's minimal. So I think that's a good question, but that would be my answer. Kevin, Christy, how do you feel about that?
Yeah, I kind of agree. I think, well, here's what I'll say. Starting anything new adds time to your case. And as you get better at it, you get faster. And I know that hurdle is hard for a lot of surgeons because you have this set, it should take me 45 minutes to do this. It should take me 60 minutes to do this. And you set the cases in that way and you set your life around that way. I think part of the issue of moving beyond that sort of I do a Nissen in 45 minutes or I do this in 60 minutes is really putting ourselves in the shoes of the patient. So it really doesn't matter if we do a 45-minute Nissen and the patient's miserable for the rest of their life. That does not matter at all. What matters is what that patient's now going through. And so I think we have to get over this sort of, well, we're adding to our efficiency of our life. It's not about us. We got to figure out as a society how to take care of our fellow humans in the best way possible. And if you add, as you do it, it will get faster. It does add a little bit of time. And in the beginning, it will add more time than once you've done it 100 times. But once you've done it 100 times, you get very facile with it. You desufflate, you tell a joke to someone, you make it part of your day, and it'll add a little bit of time, but it may prevent misery. It may prevent misery for someone if you introduce it to your practice.
Excellent.
Yeah, I think that is such a good point. That's such a good point. It's not that few seconds is not a big deal. But I think what is important is that the balloon needs to acclimate a little bit. It's sloshing around and so taking the time to desufflate, you're just standing there waiting for it to desufflate, but it gives the balloon time to acclimate. Because otherwise, I know for me, if I didn't desufflate, I'd be like, whip it in, measure it, be done. And so I actually like the stop that it gives me.
Christy, I'm going to ask you this question, and it obviously is open to both of you, but I'll start with you, Christy. President Bell asked a good question about what percentage of paraesophageals are getting relaxing incisions or mesh, and could that change the outcomes of the distensibility index? Has anyone ever looked at that? So can you comment a little bit about, do you perform relaxing incisions? I know you do because I read one of your papers about it. Maybe you can talk a little bit about when you decide to do that and how, because that again seems to me to be very subjective, measuring that tension, but maybe you can talk to me a little bit about, or talk to us a little bit about relaxing incisions.
Yeah, I think that one of the principles of the open surgery was tension, both axial and radial at the hiatus. So esophageal tension and closure tension. And we've been looking at that for several years. We do relaxing incisions, but our rate is only it's like 4% or less. It's not very often, and it's usually redos. So it's not very often. So we haven't been able to tease out flip with that. Our hope would be it'd be the same, that we were able to achieve a good closure with that relaxed incision. I think that's a really good question about mesh. We use mesh, and we can get into that. And so I don't know. I don't know if there's a difference. I'll have to keep my eye out. Maybe I'll look at I don't use mesh on the type 1s. So maybe I should start looking at that a little bit.
And Kevin, there's a question about whether the length of the waist on the endoflip might have a factor in the outcomes of a fundoplication. Do you ever look at the length of narrowing, we call it?
Yeah, and I mean, I think that's what changes when you do a fundo, right? You go from a 1 to 2 centimeter waist to a 4 centimeter waist, but the DI doesn't drop very much. And the reality is we don't know that answer, and that's part of why I was a little bit squeamish when I did my first deferring of a fundo, because I mean, I trained in an era where everything was transabdominal, but we did resection of the sac, closure of the crus, mesh, posterior gastropexy, anterior gastropexy, Nissen fundoplication, over a bougie, every belts and suspenders, like that was what we did. And I do think that once you sort of lengthen that zone of pressure, it might not necessarily be the amount of pressure, but the length of it. And now, as my length is shorter and those that I've deferred, are they going to be at risk for developing reflux later? I don't know is the short answer. I'm going to keep following them. And if I'm going back and doing toupees in 5 years on everybody I deferred, then we'll know the answer is that was wrong. Okay, I probably shouldn't have done that. But I think it's important to keep following these patients, because if they all don't come back, then I don't know that the length matters as much. Then it may be just the crural closure and getting it to a waist of 1 to 2 centimeters.
Yeah, I can say that Hoover Wu from our institution wrote a paper on that and actually did find that that there was an ideal length of narrowing that did correlate with outcomes. And that length of narrowing, I believe, was somewhere around 2 centimeters or so. And so I do think that we can use that. I don't think it's being used regularly, but probably in the end, the ideal data points we should be collecting with endoflip during hiatal hernia repair would be the length of narrowing as well as the distensibility index. But
Yeah.
Christy, Dr. DeMeester kind of was one of the first to really talk about the length of the wrap as being a factor. So, how do you feel about that? And what was some of your training when it came to the length of the wrap?
So the length of a DeMeester Nissen is supposed to be 1 to 2 centimeters max. And the wraps that I see,
But that's anterior.
I know, I understand. That is not the same as a measurement of compliance. But your anterior part of your fundo, where it comes together, 1 to 2 centimeters. That being said, I think a majority of people's wraps are longer than that. And I think this is a new, like a new frontier. I do just feel like intuitively, the longer the fundo, the harder it's going to be to vent. So we'll see. We'll see.
Yeah, and I think that's what Wu found as well, is that if you get too long, the gas float rates were starting to go up as well as dysphagia. So let me ask another question then. What if endoflip is not available? So what are the things that you're looking for? Christy, you're starting to touch on it when you're talking about, the history and doing opens, but what if the endoflip machine was broken and now you had to just laparoscopically do a repair, look at it? How are you going to determine, like when you say it looks good, what does that mean?
That's good. That's a good question. I think that, well, there's a lot of things, that go into that. I try and tailor the closure to the flaccid esophagus without any tension at all. And so if you're cranking up the esophagus, you're going to make it tighter. You're going to put more stitches in it. So you have to close it when it's just sitting there. And people's esophaguses are different sizes. Sometimes you have to tailor it to them. I actually had one lady whose esophagus was so huge and burned out from all her strictures and whatever. Her esophagus was huge. I had to leave it. I had to tailor it around there. But then as her esophagus healed, like 4 or 5 years later, I had to go tighten it again. I had to fix it. So I tighten it to that. And I think that's the most important part of it. And the other thing that I've learned over the years, that I think a lot of people do, or I know I certainly was doing this a lot. You know how when we are retracting the esophagus so that you can see the posterior crura, you're really cranking it over to the left diaphragm. And I find that you have to pay attention to where that top stitch on the left crus needs to be so that it's symmetric. So I do a lot of moving the esophagus to the center, making sure it's in the center so that I'm bringing the crura together, to avoid any sort of bowing or mismatch or dog ear on that other side. I think that's an important lesson too.
Kevin, somebody asked if you could post the references in your talk. So I don't know if you could put that in the chat for everybody, would be great. Or you can, yeah, you can put it there. Kevin, how do you feel about, like, let's say EndoFlip is down and, you have to just do a crural closure now, just with your eyes. What are some of the things that you would look at, and how would you assess the tightness of your closure?
Yeah, I mean, I think, is that okay? You want me to leave this up for a second for folks if they want it, or do you want the other I can go back to the other references too. Can you hear me?
Yeah, I think that's the reference they're asking about. I think that's fine.
Okay. Yeah, I mean, I was a bougie guy. I think 56, 56, 60. I would use it prior to the hiatal closure, and then if I was doing a fundo, I'd stop doing it over toupees because they were pretty much just standard, 270. But I think now that I have EndoFlip, I go back to some of those videos, especially the ones I know who had dysphagia, and they all looked, even though everybody's anatomy is different, we were trained to make them look the way we were supposed to make them look, and for the most part they did very, very well. But then we all had those patients that did not do very well at all, and actually were terrible, and you wonder if they would have been the patients whose DIs were lower even after the hiatal dissection. And you knew, maybe like you just presented this past week, Mike, about those with potentially ineffective esophageal motility that was undiagnosed, that you needed to make them a little bit looser. So I think that's the worry when you don't have, this type of technology. It's like when you first got ultrasound, intraoperative ultrasound. I'm an HPV surgeon. It's like, what do you do when you don't have an ultrasound? I'm like, I mean, I'm worried. I mean, yeah, I use my eyeballs and I hope that that's where the tumor was. But, at the end of the day, part of advancing in this field is integrating new technology. And, I commend you both for really laying the groundwork with your papers and things that I've used these protocols, and they do make a difference, and they've made a difference in my patients. And I think that's what all of us who are doing this should strive to do. And I have no disclosures. I think it's a really good, tool to add to your toolbox.
Christy,
So
yeah, go ahead.
Oh, I was just thinking, you're so right how you get used to it. I'm still fairly comfortable if the flip is in the other room with a curl closure. But what I've noticed is I really am not comfortable anymore doing a Heller without it. Like, I went to proctor somebody with who was doing their first poems in a different state, and they didn't have a flip. And I realized, wow, I haven't done a poem without a flip in years, like many years. You really do get used to it, and it really helps. And it's really it's funny how we get used to that.
So Christy, kind of on the lines of motility, do you feel that it's important to check motility in patients who are going to undergo hiatal hernia repair? And if you do, I guess the question then is why, and how do you alter your approach when it comes specifically to hiatal closure? Like, for example, is your hiatal closure looser when you have somebody with dysmotility than somebody with normal motility? What do you change?
Well, after your work that apparently you must have just presented at Central, I might have to start paying attention to the crow closure with the IEMs. Yes, I still believe that I still believe in the motility. I predominantly, like everybody else, I predominantly am doing partials because, we believe that it has less side effects, although I'm not sure our data is showing that. But I do because I think it helps your post-op care. People that have bad esophagus are going to struggle a little more. They're going to be okay, but you'll know and they'll know why they're advancing a little bit slower, and you can reassure. And so it's not, you don't have to think, oh my gosh, I made it all too tight. It's, we expected this, you're going to be okay. We'll just go slow. And so I do think it's important. The other thing is I do still prefer a Nissen for the really bad reflux. I mean, if someone's got raging esophagitis and really bad reflux, I do prefer a Nissen. And so I want to make sure that they're ready for it. So I'm still a manometry person for sure.
Kevin, how about you?
Less so, especially as the hiatal hernias get bigger. I mean, I'll probably do it for type 1s and the smaller type 2s, but type 3s and type 4s who are symptomatic, how accurate they are is really a question. Did they get it across the GE junction when the stomach's all the way in the chest? I almost never get manometry. And I would say that, at least in my patient population, convincing them to get a manometry is hard. And I think I know that there are centers where everybody is somehow willing to do them, but my patient population just does not like them. And they tried them and they didn't tolerate it. And I actually, if they have not been scoped by me preoperatively, I do scope them. If they don't have a recent endoscopy, I do scope them and do baseline endoflip in the endoscopy suite. So I have endoflip available for preoperative assessment as well. And so even for the type 4s, I'll assess their GE junction in the chest using endoflip, and I'll know, okay, this patient doesn't have achalasia, right? It's DI's 8, like this. And then once you reduce it, you see that. But I do fewer and fewer manometries. I do them for all the, no hiatal hernia, they're getting a manometry. They're like just pure anti-reflux patient, atypical symptoms, they're getting manometry. Those people all get manometry. The patients that I'm treating, which are a lot of these paras, not very few get manometry.
I'm going to bring up two controversial things, and I'll leave it because this is data that we've accumulated that have not been peer reviewed or published. But one is, and Christy, I think you'll for sure be happy to hear this. We presented at DDW data that shows that if you have patients in the correct desensibility index range, it doesn't matter if you do a Toupet or Nissen, they actually have the same outcomes. And I was surprised to find that, but I actually believe it. I think one of the issues is that if you're too tight, for example, with a Nissen, I think those patients would probably do worse than if you're too tight with a Toupet, probably. I don't know the answer to that, but all I can say is that a Nissen, which we've gone away from because of the data from Sweden, the randomized trial, which does have faults, by the way. Your group, Lee Swanstrom, I think it was before your time, though, did a very well-known randomized trial showing that we should probably be using a bougie when we do a Nissen. And in that Swedish randomized trial between Nissen and Toupet, a bougie was not used. And so you could argue that the increased dysphagia and seen in the Nissen group maybe perhaps was due to no bougie being used. And so that data wasn't perfect, but we've had good outcomes with Toupets. And so I'm okay with a Toupet fundoplication. And we really haven't done a Nissen in a few years. But when we look back at when we were doing Nissens, if we compare those to our Toupets in the same range, they do about the same. So the other thing I'll bring up, and it's the paper that Kevin's referring to from the Central, which again has been submitted but not peer reviewed, or at least not published yet. We found, again, something very counterintuitive, and that is that if a patient has IEM or any kind of dysmotility on preoperative manometry, their ideal range for a hiatal hernia repair is actually no different. That 2.5 to 3.5 range held true with patients with even ineffective motility. And I think that's interesting, but also makes sense. We all do myotomies, we've done poems, and if we get that distensibility, from 0.7 to 2.5 or 3, those patients, their dysphagia goes away. And I think that probably that range is going to hold true for whatever we're doing, whether we're doing a Heller, whether we're doing a poem, whether we're doing a hiatal hernia repair. I think we're going to want that distensibility around 2.5 to 3.5, and
Yeah.
again, not published yet, but that's our own data.
Yeah, no, I agree. I mean, I definitely think that that is being reinforced over and over again, that there's a sweet spot for no matter what, for the esophagus, and that is also reassuring, different centers, different people doing it, and that there is a sweet spot. And when I said that earlier about how we're letting him go, we do, but we still prefer the sweet spot. Like, we want that.
Kevin?
Yeah, I agree. I mean, I think I love your analogy to the Hellers as well, Christy, when you talked about that. I mean, we're now going to be able to use it to potentially shorten the myotomy when it doesn't need to be, half the esophagus, and to risk having a DI of 9 afterwards, where you're going to give that person reflux esophagitis. Maybe we can challenge those who said, poem is going to cause reflux for everybody, and do a 4 centimeter myotomy and see a DI of 4 that we know is in a disease like achalasia is going to be 3 in about a year, right? Like when you do endoflips on these poems, if it's 4 now, it's going to be 2.5, 3 in a year. I mean, it's going to scar in. And so I do think that as we continue to use it, it's going to help us understand that sweet spot. And that sweet spot's going to be different for each patient, because when you talk about ineffective esophageal motility, that's a minor motility disorder. And so we think some of that's from the reflux, right? It's some level of damage. And now you fixing the reflux, you're getting your DI in a good range. That should improve, right? And when you do that endoflip in the endoscopy suite, and for the listeners, the difference between doing it in the endoscopy suite and the OR is that they're awake. And so you're going to see repetitive antegrade contractions. You will not see those in the OR. You're just looking at a DI and a diameter. And so you're going to get some functional data from that when they're not as sedated. Now, there's a lot of anesthesia papers looking at whether you can give propofol or not. And I think that really to get the best, you probably should be under true moderate sedation, where they're kind of awake and you're seeing the balloon, contract, if you will. But you do get a little bit of different data in the endoscopy suite than you do in the OR.
Yeah, I mean, that actually kind of leads to one of the questions. And that is the, manometry versus endoflip preoperatively. The specific question was about patients with dysphagia. So Kevin, I'll ask you, because you said you don't use manometry every time, or you don't obtain it every time. Even if a patient has dysphagia, you wouldn't obtain manometry in a patient with a type 3 hiatal hernia? You would just assume it's due to the hernia and no manometry?
Well, I would do an Eckert on them. I mean, I try to get standardized symptom severity. And if the Eckert score was high, I'm going to scope them. I'll do the endoflip. And if the DI is low, then I would get a manometry. I mean, I think it's still the gold standard, and it does give us different data. And so if I have any concern at all that they have an underlying major motility disorder that would potentially require something other than just the hiatal hernia repair, then yes, I'll get a manometry. Like if I think I'm doing a hiatal hernia repair and a Heller, then yeah, I'd want to know a manometry beforehand. I will say there was one patient where I didn't get a manometry. I closed the hiatus. It was not tight, and the DI was under 1. And I said, this person has a motility disorder. And I didn't have a manometry preoperatively, and I stopped. I didn't do a fundo, but I didn't do a Heller either, right? I stopped, and I sent the patient for GI workup and motility, and he had EGJ outflow obstruction that they managed medically. But if I didn't have that data, I probably would have done a Nissen on him.
Mm-hmm. Christy, I think you still get manometry just about on everybody pre-op, or is there some you know aspects in the history from the patient that, or maybe radiologic findings that would make you get manometry, or do you just get it on everyone?
We get it on everybody. It's just part of our pre-op. They have a manometry before they come to consult. So I think that the only agreed upon reason to get the manometry is to rule out achalasia. So if you feel confident in your clinical judgment, I'm not judging you, but we get manos on everybody. I've been collecting charts over thousands of paraesophageals to see how often do you have achalasia, true achalasia, and it's 6. It's been almost 20 years and there's 6. So it is super rare. When I get more than that to say, maybe I'll publish it, but
A couple things I would just point out is that, of course, I trained under Christy and Lee. And so my whole career, we've obtained manometry on everybody preoperatively. And I agree with everything Christy said. It was nice to know, somebody's motility status. And then there was a period where maybe we tailored things. They'd get a toupee if they had, poor motility versus a Nissen if they had normal motility. But I will say that EndoFlip is slowly replacing manometry for us. So if I am doing the pre-op endoscopy, I will absolutely do an EndoFlip at that time. And I will get not just the sensibility of the LES, but I'll also get the panometry or the motility reading. And if it's normal, which it is most of the time, not all, but most, I won't get manometry. And I will only get manometry if I have a questionable desensibility or if there's poor motility. I will say now, though, that we've learned that, Kevin, you can actually get panometry in the operating room under general anesthetic, but it has to be under TIVA or total
TIVA,
intravenous anesthesia.
Yeah.
Sevoflurane inhibits esophageal peristalsis. And so you cannot get motility with EndoFlip when somebody is under, sevoflurane. But under TIVA, that's our routine now. And I'm actually getting a little bit away from getting routine manometry now, because what we actually published a study where we found that they're basically 95% of the time correlating. And the interesting thing, and Dusty Carlson at Northwestern found the same thing, those 5% where we see that manometry is telling us one thing and EndoFlip is telling us something different. If you look at time barium studies and dysphagia, they align more with the EndoFlip reading than they do with the manometry. So I think we assume that manometry is the gold standard. Christy is probably the best expert at manometry on this call right now. But I think she would admit and tell you that manometry is not 100% correct all the time either. And so I do think we have to be a little bit careful assuming that manometry is always correct. Christy, is that a fair statement?
oh, I agree. I use it. I think of it as a screening tool. We use a lot of the Flip 2.0, the long balloon also. But when we see like an EGJ outflow obstruction, they go straight to Flip. Like we check them all. So I think it is an evolution. But you're gonna have to pry it out of me though. I'm so comfortable looking at it and knowing whether or not they've got good motility. But again, I do respect like a lot of the stuff that's come out with links, and that look, if they don't have pre-op dysphagia and they don't have achalasia for whatever reason you think they don't, then it doesn't help. I do respect that.
I want to be clear that I don't think manometry will ever go away. It's absolutely valuable, but I do think for those people that maybe don't have access to manometry, EndoFlip is a wonderful technology to have because it's very versatile. You can use it in the operating room and the GI lab, and it gives you, again, its correlation with manometry 95% of the time.
Yeah, definitely. And it's easier to read. It's easier to train. So I agree. I'm a fan.
I don't know if either of you do bariatric surgery, but there's a question about if you're doing crural closure during a bariatric procedure, who needs a hiatal hernia repair, what the experience is there. Do either of you have any comments on that?
So I'm a recovered bariatric surgeon. I was a bariatric surgeon in the beginning of my career, and I am, fun fact, currently the only bariatric surgeon in our center because everyone's at ASMBS. So I often cover for the week that everybody's at ASMBS. So I'm currently a bariatric surgeon. So you asked at a great time. I'm waiting for that middle of the night internal hernia to go take care of. But you know, we so far our bariatric surgeons have not been using it intraoperatively, but we've been talking about anyone who's bariatric who has, you know, dysphagia preoperatively or things that you're worried about motility. I will get a referral to do that patient, you know, preoperatively. I think again, if I was doing bariatrics and I had it was like one of these para sleeves or para bypasses, I think I would absolutely use it because again, I would want to know what the DI is after the hiatal closure more than the standard bariatric procedure that you're going to do because that's going to be irrelevant. But you get dysphagia post-bariatric surgery, and if you're having a hiatal hernia, I would want to know what the DI was after you closed the crura and whether or not it was potentially closed too tight or you could have left it a little bit looser. Again, you're going to be doing potentially a sleeve or a bypass, which is going to change physiology significantly when you're comparing a standard anti-reflux operation. But again, that's an area that's ripe for research. So people who are doing bariatrics and hiatal hernias, get your EndoFlip friend and come get some data and publish it. That'll be published immediately.
Yeah, I would answer that because I do bariatric surgery. I would not do any crural repair, whether it be for a bariatric patient or not, without EndoFlip personally.
There you go.
And yeah, so I do think that you know, it's the same idea. And I think we have to keep in mind, by the way, that obese patients are more likely to have poor motility, by the way. So probably even more important because you know, what we have found is that, again, that ideal range is no different whether you have bad motility or normal motility. But if you have bad motility and you're too low on the distensibility side, those patients have worse outcomes than patients with normal motility that are too low, which makes sense. And that's exactly what our data found. So more important that you're in the ideal range, but it's the same range for a dysmotility patient. And then I want to get to the end here, but there's one question that I think is a good one. And it'll be our last question. And that is whether or not you do anterior closure at all on the hiatus. So are all of your stitches posterior? Do you ever use anterior stitches? You know, the person states that Volanovich and Geertz have published on recurrences more likely being anterior, which I think we would all agree with. But does an anterior stitch prohibit that, or does it prevent recurrences better than just posterior stitches? So Christy, why don't we, actually, Kevin, I'm going to start with you. We'll end with Christy on that question.
Yeah. So I had a video of, and this is actually the video that's attached to the manuscript that Dr. Al-Khatib, who's on the one of the participants showed, which is that when I had one case where I don't often do anterior, but sometimes it looks like it would lay more, you know, kind of as Christy was talking about, you know, lay flaccid if you did more anterior repair. And the DI dropped with the anterior stitch to like under 1. And so in real time, I cut the stitch out and watched it go from 1 back up to like 4 or 5. And so I still knew that I needed to do something. So I started closing more posteriorly. I closed posteriorly and it came into the appropriate range. And so I just think definitely seems to be more tension anteriorly when you're pulling the anterior crura because it's the wider area, like when you're closing like a zipper from the bottom. And so I do think the anterior stitches may create a little bit of a higher pressure zone. And that's based on my N of 1 where it dropped below 1.
Christy, what is your thoughts on anterior stitches?
Well, I never say never because whatever, you have to do what you got to do, but we call the anterior stitch the dysphagia stitch. It just is. And that's why.
Okay, there you go. That's perfect.
Yeah, you're totally right. And And a lot of people criticize, they say that the esophagus has a speed bump if you have too much of a posterior closure. I just don't see that at all. But really wanting to avoid that anterior stitch is why I started paying attention to crawling up that left cruise to make sure that it's nice and tight, like that's super tight, but like it's nice and tailored anteriorly. There's not a gap or looseness. Um, I wouldn't say never, and I wouldn't say never, no one should do it. But I will say that the reputation in our unit is it's the dysphagia stitch.
That's fantastic. I absolutely love that. And I'll send you that video just so you can see it go to 0.9 after an anterior stitch, which
I
is
love that.
definitely going to be a dysphagia case.
You're like, dang, that's not good. No,
That is
don't like
not
that
good.
one.
That's not one. Even Christy would not leave this one.
That's right.
But she wouldn't have thrown the stitch in the first place. So
No.
there you go.
But I would have said, aha, see?
I really appreciate you guys. Peter Janu, a good friend from over the border here in Wisconsin, just asked a question about billing, and all I would say is we do bill for it. It doesn't bundle into the procedure, so it is 91040. You will get reimbursed for it. It is not a high reimbursement, but the hospital.
0.9.
Yeah.
0.9 work RVUs, but
Yeah, you have to document the findings in your operative note. So you can't just say you did it, but you have to actually write down the distensibility index at the very minimum. If you got any other, I put in all the numbers in there, but you do get reimbursed for it. The hospital does get reimbursed. We're actually looking at that right now because I don't know the answer on, how much of a margin there is one way or the other, but hopefully we'll have that answer within the next year or so. But we'll end there. Thank you guys so much, Christy, Kevin. It's been a pleasure working with you on this webinar, and just having your knowledge and experience is outstanding. I think all of us, my personal feeling is that hiatal hernia repairs are the least standardized procedure on the planet. And I think it's really good to hear how everybody else is doing it and what technology you're using to standardize your repairs. Obviously, your patients do very well. You guys have outstanding reputations, and so I think we're all lucky to hear from you. Thank you very much. We will
Thank
see
you so
everybody. We'll see everybody at the meetings, and thank you for joining. And I hope everybody has a good summer.
Thank you so much. It was fun.
Take
Thank
care,
you.
guys.
Take
Bye-bye.
care.
See ya.